Well, good afternoon, everybody. My name is Garrett Schmidt. I'm the CEO and managing editor for VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by Arcadia. And this one's called From Insight to Action, Applying Trends to Your Population. Glad you all joined us today. A few items of note before we get started. This is a traditional webinar format, so you have joined in listen only mode, so you don't need to worry about uh, turning off your camera or your microphone, anything like that. We can't see you or hear you, but we do want to hear from you, and we're going to have a time for some Q&A towards the end of our presentation. So if you have a question at any point during the presentation, you can use your control module. You have a little thing as an attendee there that you can drop your question in, and then we're going to get to as many of those as we can. If for some reason we're not able to get to yours, we run out of time or whatnot, don't worry, someone will reach out to you via email to make sure that we get your question answered. So even if we're just wrapping up towards the very end, go ahead and drop your question in there. Also, the session today is being recorded. So what's going to happen is when we conclude, you're going to receive an email maybe about an hour or so afterwards, and there'll be a link to the recording as well as to the slides for you to download, and that way you can review it at your leisure, share it with colleagues and friends, and we hope that you do. And with that, I think we can move on to introducing our speakers today. So very excited to introduce Mr. Justin Brooks. He is a consultant with government programs with Intermountain Health. And then also we have Mr. Timmy Delvecchio, and he's the Senior Director of Member Services with Arcadia. So welcome, gentlemen.
Thanks, Garrett. As he mentioned, Justin Brooks, I work for Intermountain Health. I've been in the healthcare industry for about 14 years, started in software and then moved to the health system side. I've been with Intermountain for about 5.5 years now. Consultant's a bit of a misleading title. I think a better one's a program or director of our accountable care organization. My primary responsibilities are the day-to-day minutia that comes with managing an ACO, as well as some more of the fun things that we'll talk about today, looking for ways to improve care, reduce costs, and look at the long-term strategy of the ACO. I've been working with Timmy really since I started at Intermountain. It's been, 5 or 6 years now, Timmy, and I'll turn it over to him and allow him to introduce himself.
Awesome. Thanks, Justin. My name is Timmy Delvecchio. I'm a senior director on our member services team here at CareJourney by Arcadia. So it's basically my job to make sure our customers make best use out of our products and data. I've been at CareJourney for many years now, and for almost all of them, I've been working with the Intermountain team and Justin and his colleagues as well. So super excited to be able to showcase, a lot of the great work that we've done together. And so the focus for today will basically be to explain, what is first-party internal data versus third-party external data. How can they be used together to better contextualize performance and identify areas of opportunity, right? So the way I like to think about this is basically an assessment to action framework. How can I use third-party external data to assess where my organization currently is, and then use first-party internal data to actually take action on whatever trend I'm seeing, and we'll have some, pretty exciting examples for the audience today on that as well. But before we do that, let's talk a little bit more about each of our respective organizations. So on the next slide, just a little bit about CareJourney by Arcadia. So CareJourney by Arcadia is basically the arm within Arcadia's health data platform that's heavily focused on value-based care market intelligence and provider intelligence. So we take all of this benchmarking data to help organizations drive action around, designing networks, managing populations, and assessing provider performance. And so how do we do this? We have an innovator's license with CMS, meaning that we have 100% Medicare, Medicare Advantage, and Medicaid data. And yes, I said 100%, right? So it could be a knee replacement in Hawaii, an annual wellness visit in Texas, urinary catheter claim in Maine, too soon. And we have access to that data, right? And so you can combine that data with a large commercial data asset as well. And you have just a super powerful data set for benchmarking across both, value-based care and non-value-based care use cases as well. And so over the years, as we've been building out our capabilities, Intermountain has been an amazing partner over the years, both actually utilizing the data, but really providing feedback to make this data, as useful as possible. So obviously super thankful for that as well too. So Justin, while the Intermountain name does not need much of an introduction, why don't you tell us a little bit more about Intermountain and the markets that you're in?
Yeah, for sure. Growing up here in Utah, it was just kind of a thing that was the hospital, and it wasn't until I got older that I realized what a great organization this is. And then having worked for Intermountain for a number of years, really seeing why we've become a leader. But as you can see on the slide, quite a big geographical area. Over the past 5 to 7 years, we've expanded our footprint from what was Utah and southern Idaho into Nevada, Colorado, New Mexico, Arizona, Wyoming, up into Idaho and Montana. So a lot of rapid growth over the past couple of years brings us to about 400 clinics and partnerships across the 8 states that I mentioned. Got 33 hospitals, including 2 world-class children's hospitals with a third under construction in Las Vegas. And so really big footprint. We've got 64,000 caregivers, and of those 4,200 are providers. And I think even the more important thing, and we'll talk a little bit about this later, but we've got partnerships with around 5,000 independent physicians. We can't do all of this work on our own, and so it's important that we partner with others. As you can see, it's quite a big footprint. I actually created a custom map, but my marketing team wouldn't let me use it. But it showed the geographic footprint that Intermountain covers. And to put it into context, north to south for you people on the East Coast, it's from Miami to about Toronto, and then from Connecticut to St. Louis. So that's the size of our geographic footprint. We have one county that's the same size as New Jersey, but it has 14,000 residents. And so we have to do things differently. And that's where Care Journey really helps us understand different opportunities. We can't just refer people to the clinic because it may be 6, 7, 8 hours away by car. And because of that, we've been really invested in telehealth. We've had 3 million telehealth patients treated. And for my role, we have 2 ACOs that total about 75,000 beneficiaries. That's what we're focusing on. Like I would assume all of you on the call, we're really trying to figure out and tackle this balance between value and fee for service. But I think most importantly, our commitment is to the patient and helping them live the healthiest lives possible. So with that, I'm excited to share kind of what data and the work we've been doing that Timmy's mentioned. And so I want to get a little bit more context from the group on what you're interested in. So we're going to start with a poll and really look at what are your biggest challenges in turning insight into action.
All right, you are going to see this up on your screens. And this is choose best or the one that best applies. Again, what's your biggest challenge in turning insights into action? Is it too much data, hard to prioritize, limited staff to operationalize insights, unclear benchmarks to compare against, siloed data across systems, leadership alignment or buy-in? And if you're saying, oh my goodness, it's all of these things, then just pick the thing that most applies currently to your situation. And this is, by the way, this is anonymous information here, and we're going to share the results with you so you can kind of see where you stack among your colleagues. So it's just kind of a fun way to get engaged with this discussion. But I'm going to give it another maybe 5-10 seconds here for the results to come in, and then we'll close it down and show you what everyone said. What is your biggest challenge in turning insights into action? Okay, I think most of the results have come in, so I'm going to go ahead and close it down in 5, 4, 3, 2, and 1. There's always a couple that are right there at the very end. So here we go. I'm going to end it and share the results. All right. Timmy, Justin, are you able to see this on your screen?
Yeah, we can see it. Thanks so
Yeah.
much. Yeah, not gonna lie, it's kind of fun watching the results like change over time, like in real time like that. That was pretty cool. I don't know, Justin, the first thing I see looking at this, which, I think is pretty insightful, is actually a lack of response on leadership alignment or buy-in, right? Which makes it pretty clear that like data-driven insights is pretty crucial for being able to determine, where an organization should take action. So glad to see that, the biggest challenge isn't in that picture as well, which is interesting, but, something I've definitely heard across my interactions with different clients as well. It's just that siloed data across systems, right? You have, and we'll talk about this a little bit later. You have data in EMR, claims data, other data parts. How do you kind of look at all of that holistically to be able to determine, what path moving forward as well too. Cool. So thanks everyone for interacting with the poll there. So with those results in mind, let's kind of continue on. So I'm not gonna lie, I've been on this Mount Everest, documentary kick recently. Honestly, just like any mountaineering documentary. It's ironic because I'm terrified of heights and I like struggle with step stools. But anyways, I thought we could set the scene by, creating this analogy to a general mountain, right? And so for value-based care in particular, our end goal is reducing costs for managing a population while maintaining a high quality of care. You could argue it's not really a peak per se, it's more of a continuous journey, but for the sake of the analogy, let's just go with the mountain. And so clearly, right, there are many, many different ways to go about this and climb, this mountain. Some paths are easier than others, right? Some there might be a huge ice fall you have to climb. And so for many metrics and strategies, right, it might be easy just to say, oh, we need to reduce this metric or we need to increase that metric, right? But really where the challenge is, getting over that, initial inertia to change incentives, change provider behavior, and obtain ROI. And I'm not talking, solely financial ROI, right? But really around patient outcomes as well. And that can be super challenging. And so you might have, ACOA, let's say, might be kind of more of a slower, methodical organization. They slowly make their way up the mountain, focusing on, one new initiative per year, right? ACOB might go full Alex Honnold, free solo, tackle a dozen initiatives where they fall below, the ACO or regional average, right? And so this is where our drivers of success framework meets that assessment and action framework I discussed before, right? How can we perform a maturity assessment, a performance assessment on our organization on these drivers to identify not just where we have the most opportunity from the third party context, but what is the actual actionable opportunity where we can use first party data to change behavior and execute a plan, right? And so that's definitely why I'm super excited to have Justin talk to us about what Intermountain has done, because I've always been impressed, over the, many, many years that, I've been working with them about their ability to, interpret data in the context of regional or national performance, and then turn that into an actionable plan. And obviously that's what we'll walk through today. So we kind of have a few tips that we'll talk through. We'll talk through the tip and then see that data, live in action as well. So tip number 1, bring together as much data as possible, right? So let's start by actually just defining what do we mean by first party internal data, third party external data, right? So first party data is data that an organization has directly from its own sources, right? So in healthcare, that could be EHR data, claims data, ADT data, questionnaires, care management enrollment data, right? And going back to the poll, right? All these data, it's important that these data sources don't live in silos, right? But can rather be combined into something where you can look more holistically, right? And so this internal data, it can be used for things like performance tracking, aligning patients with the care plan. It's often granular, identifiable, right? Now, third-party data, this often comes from outside sources. So this could be things like the CMS PUF file, census data, as we were talking about before, the 100% Medicare, Medicare Advantage, Medicaid data sets as well. And so these third-party data, right, help provide benchmarks, give you insight into either markets or providers where you might not have as much data. And while it might not always get to the patient level, it provides context, right? And I think that context is essential to be able to figure out what action to take. So to give kind of like a goofy non-healthcare example on why context is important, right? Let's talk basketball. The playoffs are in full swing. Do you know who's not in the playoffs? My Washington Wizards, right? You can put your condolences in the chat. But if you look at the last 10 years, their points per game have gone up 4 points a game, right? So if you weren't on this webinar, you might be thinking like, okay, they're improving a little bit. But in that same time period, the NBA average went up 13 points in that same time span. So even though the Wizards were increasing, nowhere near catching up with the league, right? So the power of that, broader context helps provide additional context around a given trend, which is super important, or sad if you are a Wizards fan like me. But bringing this back to healthcare, Justin, I definitely kind of want to hear your perspective on that idea of context when we were looking at a recent spike that was in the news around catheter spend.
Yeah, this is a great example to kick us off and bringing an example of bringing together data from different sources. So this all started when we got a monthly expenditure report, which is a report that's unique to the ACO REACH program, but it summarizes by different category your expense for your ACO. And in one particular report, we noticed a huge jump in our DME spend, and we started to dig in because it was quite a big variance and didn't look normal, to the point where we emailed and asked if it was an error in the way that the report was generated. Coincidentally, like a week or so later, we had our monthly touch point with Timmy and Care Journey, and Timmy came prepared and had brought up this trend, and I think probably showed us these exact same graphs that we're looking at now. Only he was able to use our CCLS, which is first party, but I think in this context it was third party because he was bringing it to us. And then also national benchmarks that you can see in the table below to say, hey, although catheter spend is going up, this is a huge problem for you guys. And with that, we were able to understand what the issue was, and then act upon it. And in this instance, the action wasn't reduce catheter utilization, but it was more on the advocacy front. If you followed the issue in the news, there was a lot of fraud around catheter billing and spend. And so we were able to reach out to other ACOs and join together to go to CMMI and CMS and say, hey, this is an issue, and we need to address it right away because it's really impacting our spend, and it's not only impacting our spend, but it's taking our time away from focusing on delivering care that matters to the patient. So it's a really good, I think, example of bringing together different data sources, aggregating them, and sort of triangulating to make sure that this is a problem, and we need to address it. And it was really because of what Timmy brought to just like a regular meeting. It wasn't something that was like an emergency or that was called out. We were able to act quickly and lobby CMS, and we got an emergency rule put in place. I think working together with a bunch of other ACOs. So it was really good, I think, primer to the benefit of bringing together as much data as possible.
Yep, exactly. No, I think you nailed it, Justin. Obviously catheter spend was a big, topic right now. There's a lot of talk about wound care and what's next, right? And so being able to use this, third-party data to be able to take, okay, we're seeing this for our organization. Is this happening in our region? Is this happening in our nation, right? Is helpful context to be able to understand what could be some of those root causes behind some of these patterns that we're seeing as well too. Cool. So moving on to our second tip, Don't boil the ocean, right? Or don't climb Mount Everest in a day, right? There's so many metrics and ways to compare your organization to others, but it's really important to focus on metrics that drive what you are really trying to achieve and have the ability to change the narrative, right? If you're already in, the 97th percentile for reducing avoidable ED relative to other ACOs or relative to the nation, there might not be as much like actionable opportunity to improve that. But if there's a metric that's clearly tied to ACO success, right, and there's an opportunity that you know how to impact it, then showtime, right? And so some tips that we have here at the bottom in terms of being able to look at that in terms of what we've learned over the years, right? Just like I mentioned, focus on what are actual impactable trends. If there's a trend that you see a pattern, but there's not much you can do about it, it's good to know, right? But it's also important to be able to assess the feasibility of being able to impact that. Next, rely on transparent methods and metrics. It's important to know how a metric is being calculated, right? Numerator, denominator, exclusion, inclusion criteria. So that way, when you are understanding the trends, but then also communicating it with leadership, providers, the broader network, being able to explain exactly how a metric's being calculated and how to interpret that is essential as well. Next, review holistic performance across all contracts. So being able to understand, okay, is this a problem for just our, Medicare line of business? What about our Medicare Advantage? What about our commercial panels as well? Being able to kind of look holistically across all contracts to see how patterns are similar, but also how patterns are different is super important as well. Identify a relevant benchmark, right? So if you are looking, if you are an MSSP ACO based in Washington State, should you be comparing your, inpatient spend to, Augusta, Maine? Maybe, maybe not, probably not, right? So being able to identify what is that cohort that we want to identify that benchmark for. Sometimes it's regional versus national. Sometimes for academic medical centers, it might be other academic medical centers. Maybe rather than looking at all ACOs, you only want to look at successful ACOs. So being able to identify different benchmarks to see how that changes the trend is super important as well. And then finally, look for variation in performance. Using trended analysis year over year can help better understand, okay, is this a recurring trend, or could this just be maybe an anomaly for 1 year, or are we consistently seeing this pattern as well to know whether or not it's something that's actionable as well. So being able to separate the signal from the noise, as someone put it recently, I thought is definitely a great approach as well. And so, Justin, going back to this, thinking about one of the metrics that we had tied to ACO success using our full Medicare data set was PCP utilization. So what was that path like for Intermountain in terms of identifying an opportunity, and how did you actually, turn that into, impactable change for your organization?
Yeah, this is a really good example. And I think this is one of the first times that we took third-party data and turned it into a full-scale initiative. And I'll kind of walk you through the steps there. But started with a blog post, and I think it was 2 years in a row where Care Journey had published this blog post on ACO performance and had identified a correlation between percentage of primary care visits per 1,000 members, or PCP per K, and the savings per capita of ACOs. And as you can see on the chart, we had a really low PCP per K, and our savings per capita was also about middle of the road. And so it struck me as, hey, this is something that we could probably act on. But before we go in and ask our organization to change and to increase primary care visits, let's take a deeper dive. And so the chart you're looking at here was us looking at our performance relative to our region. And we're in a really unique region with some unique demographics. And so that's why I think it was important not to just look at all ACOs, but what's happening, in our neighborhood. And we found that this bore out that there were ACOs that were doing more primary care visits. As you can see, we were, I think, the penultimate performer here, and it suggested that we did have room, and if we were going to do something, that it would improve our savings. The other thing that was called out in the blog post is, if you remember your economics or your tax policy lessons, whatever you studied, there's the Reaganomics or the Laffer curve. And so there were groups that did too much primary care, and it impacted their savings. And so we wanted to be careful that we didn't just blindly open the primary care floodgates. We wanted to understand what was the right, and I'm going to refer to it as dose or number of visits of primary care for each individual. And so after we looked at the data furnished by CareJourney, we turned inside and looked at our historical claims, clinical data. We brought on a health economist to help analyze or determine what's the Goldilocks amount of primary care for each ACO member, given their demographics, their risk, their tendency for having a chronic condition or current chronic conditions. And the results were really interesting. In some cases, we found that there was a small group where the one visit actually increased their costs because they were getting a visit and they didn't need any primary care, didn't have any conditions that needed managing. So it was like as low as one visit was the right amount, and as high as 6 or 7 for the high risk patients. And so with this, we launched an incentive program, not only in our ACO, but I'm going to back up. We looked at this in our ACO, but also in our Medicare Advantage population. And the numbers the recommendations were different between programs, but we launched an initiative or an incentive program to pay provider groups that we contract with to pay them a bonus for their net increase of primary care on moderate to high risk patients. So any visit above a patient's 4th visit, they would get a bonus. Any visit beyond the 6th or the 5th visit, they would get a bonus on. And we saw this really increase the focus of the primary care providers on primary care, and the leadership's need to expand access to primary care. And it was so successful. We're still waiting for what's the long-term cost curve look like on this, but in terms of the attitude and the incentives and the adoption, it was so successful that the Intermountain side, the employment side, so we're the ACO side and we manage the value-based contracts, but the employment side adopted this type of model into how they pay physicians or their physician compensation model. And so it's a really good example of looking at data, understanding the data, but then also what's the best fit for our organization, and then doing something that really is going to benefit and improve the lives and the health of the patients that we take care of. And so Timmy talked, that was one really good story. Timmy also talked about in his tips is identifying data and using it as early as possible. So that's our third tip, is to act as soon as possible. As you probably are aware, the wound care expense has really mushroomed over the past couple of years. We're going to talk about bringing data together to address that. But I think the important thing to talk about or to set the stage is there is a data feed, and Timmy's going to talk a little bit more in detail about this, called BCDA data, and it's in ACO Reach. You get access through this data feed to pre-adjudicated claims. And so we've brought this pre-adjudicated claims data together with our CCLFs to try to address the overarching wound care problem. And really what we saw in working with Timmy was a specific or a huge jump in wound care expense on some specific CPT codes from 2023 to 2024. And that was, I think, helpful because we were able to see not only the expense, him calling it out for us, but then also where we fell relative to other ACOs. and that it was a problem. It was something that we needed to address. And so, knowing that, we turned to our first party data, internal data, to look back at these high cost episodes. And what we found was that in most cases that were high costs, is they were short, brief periods of treatment where the patient would have visits multiple times a week for a couple months, and then the treatment would cease. But in that short time frame, we had a few patients who had racked up expense north of $1 million in just a few months. And it was often unnecessary. I think in every case we reviewed that there was a better way to treat that patient. And so, knowing this, we can't really rely on like the fully adjudicated claims, because by the time we receive the file, ingest it, get it into our reporting, it's too late. Like that type of episode has happened. And so we worked with CareJourney to get immediate access to our pre-adjudicated claims data. We're working on a feed that will take this data and push it right into our data warehouse. But anyone who works in a healthcare organization knows that that's going to take time. So we got immediate access to our pre-adjudicated claims data. And so what we've done is we took the data, and I wrote a query that, using this wound care data, first identified the overall wound care cost for the patients, lined it up to the attribution so we could look at their charts, review for medical necessity, and then go have conversations with those primary care providers with those patients as needed. And then also identify providers who have a history of billing just these high cost wound care claims, and basically they're after high dollar treatments, and that's all they focus on. And so that kind of set the stage to have some tough conversations with providers in the market, and discuss how they're treating patients. But now we're to the point where, in this report, using the pre-adjudicated claims data, that we can know within a few days that when a patient has received their first high cost wound care treatment. So if they have a claim for one of these CPT codes that we flagged, we know within a few days. And then we have a weekly work group meeting where our medical directors come together. We review the patients, who their primary care providers are, and then that day they reach out and set up appointments to talk through the situation and the specific case for their patients. And really, our role here is we want to make sure patients are getting the care that they need. And oftentimes, like I had mentioned, these treatments are unnecessary and they're really high cost. And so we step in as someone who can educate both the primary care provider and the patient, and then advocate to make sure that they're getting the appropriate treatment that we need. And so I think there's a lot of potential here. This is just one instance where we've used this data, but it's been super helpful to where we're not, to use a baseball reference, we're not throwing to second base when the runner is rounding third. Like we're ahead of the game, and we're able to step in before a patient comes and says, why do I have a $50,000 wound care bill? So yeah, a lot of great work there, a lot of great resources. I'm going to turn it to Timmy, and he can kind of zoom out and show you and explain to you all the differences between these data feeds.
Yeah, thanks, Justin. I think, this particular example that Justin walked through around wound care really talks about, the connection between third-party external data trend with looking at first-party, internal data, but not just first-party internal data overall, but the fastest possible way to get that data. Because again, as Justin mentioned, getting that data a few days after the service date versus 3 months after the service date makes a huge difference in that impactable component we were talking about before. For those of you on the call today who, this is your first time hearing BCDA, I want to give a quick overview on what that is and some of the use cases that data feed can be used for. So BCDA stands for Beneficiary Claims Data API. And for our ACOs on the line, it's a great way for ACOs to be able to, get claims data in a much more timely manner than existing claims data sources like CCLF files as well. So for those of you in an MSSP ACO, CMS makes adjudicated claims available, and these are within 14 days of the actual service date. For ACO REACH entities, this is 2 to 4 days, and this is the pre-adjudicated claims, which Justin was talking about before, right? So, rather than waiting for, 2 or 3 months of claims run out, at that point, it's pretty much purely retrospective analysis of woulda, coulda, shoulda, right? With this BCDA data, you're able to identify either an occurrence, an event, and then take action on that. So Justin walked through wound care spend, but to give you all some other examples, maybe you have a clinical pathway for a patient who gets diagnosed with a certain chronic condition, or maybe they get diagnosed with a certain type of cancer where, there isn't 3 months to, we just found out 3 months later. You need to know as soon as possible to be able to put in, whatever clinical pathway you have in place. So being able to use a data source like BCDA to be notified of a change in a patient's condition can help then enroll that patient in whatever care plan they need. Another component too is, let's say you're making an action list for your care management team or for your providers. Imagine if you give a list to a provider with these patients need a colorectal cancer screening, an annual wellness visit, diabetes eye exam, and you give that to a provider, right? And the provider looks at it and she says, Timmy, I did this one a month ago. I did this one 3 weeks ago. Is your data up to date? Is there a bug somewhere? You lose that trust pretty much instantly just because of that large gap between the date of service and when you're seeing it. BCDA shrinks that gap. So that way you have the most accurate, up-to-date lists available for the team, which will make the team more efficient, make sure that they're focused on patients that actually have a care gap as well. And so you're able to react faster as well too. So again, the BCDA data is super powerful for that as well too, and super excited to see Justin and the Intermountain team and many of our customers as well leveraging this data source that wasn't maybe previously available a few years back as well too. So those were kind of 3 tips overall that talk about using third-party external data to be able to better contextualize performance. And then we talked about not just that, but also the ability to then incorporate more timely data, right? So going back to the first poll question, we kind of talked about the idea of data in different silos, bringing that together as well too, and being able to identify relevant benchmarks as Justin was talking about with the PCP example for tip 2. So we'll close out here with another poll before we go into the Q&A. So this poll question says, what's a trend you are trying to act on? This one is, I believe it's a choose all that apply. So I'm definitely interested to see kind of what the audience says across these as well. So we'll give it a little bit for you all to put in your votes.
All right. Yeah, you should see this up on your screen and we see the results coming in. What is a trend you are trying to act on? Network development, risk adjustment, cost management, outcomes and quality performance. And if there's something else that comes to mind, feel free to drop it in the chat. All right, I think it's pretty much slowed down at this point, and most of the responses have come in, so I'm going to close it down in about 5, 4, 3, 2, and 1, and we will share the results.
Awesome. Thanks, Gary. Okay, interesting. So I don't know what I would have expected, but either way, I think this is really insightful as well. Not surprisingly, we see an overwhelming number of you interested in just outcomes and quality performance. And so a lot of what we were talking about in terms of contextualizing performance connects really well into there as well too. Looks like very similarly, cost management, not surprising, especially given what makes organization successful. As we talked about before, being able to manage that cost while maintaining a high level of care for patients. A little bit lower on the network development front in terms of that trend as well, which is interesting as well too. Cool. Thanks, everyone. And so moving on to the next slide we have here, while I'm talking through these two items, feel free to put any questions you have for Justin or myself in the Q&A section as well, and we'll see if we can address them. But in the meantime, it would not be a Care Journey webinar if we did not give out data Oprah style, right? So if you're interested in seeing metrics across to see your organization and then see different KPIs and how they compare to others as well, just type yes in the chat. That's the benefit of third-party external data. You all don't have to send us any data, and we can still show you all of these benchmarks, how you perform, where there's areas of opportunity as well, right? So super powerful in terms of using that, a third-party data set like that too. So just type yes in the chat. Our team will be taking note of who records yes, and then we'll make sure to follow up with that data as well too. And then, of course, I want to highlight an upcoming webinar that we have with our friends here at VBC Exhibit Hall. This one's going to be looking at how to best operationalize market insights across the enterprise as well too. So we'll have the link to that, but definitely looking forward to kind of continuing the conversation there as well too with that upcoming webinar as well. And thanks in advance to Garrett and his team for all of his help when it comes to being able to present these webinars as well. So Garrett,
Yeah, and
let's
I'm
see.
dropping that in the chat here right now, the link actually to this next webinar in case you all want to sign up for it. And again, it's free just like this one, and we'd love to have you there. And we'll send a reminder when we send out the little thank you email afterwards with a link to this recording. We'll also have a link where you can register there as well. But yeah, we do have time for some Q&A, and so let's see. If you have a question for either of our speakers or just in general, go ahead and use your control module to ask your question, and then we're going to get to as many as we can today. So in no particular order here, I'm going to jump right in. And the first question is this one, and I think this is directed probably to Justin here. Other than wound care, how else are you all using BCDA?
Yeah, great question. As I mentioned, it's not quite fully integrated into our data warehouse yet. So right now, one thing that we're doing at the recommendation of Timmy is we're looking at changes year over year on HCPCS codes to try to monitor trends that may be emerging. We had a bit of a false start. We saw a huge jump in a trend, and we dove in, and it ended up being hospice care, and that was great. We're happy that that's happening. I think another example, and that this was a conversation that our operations team we had with our operations team just last night was how can we improve our efforts on there's an ACO specific measure called timely follow-up, but then I think there's a larger 7-day follow-up measure out there, and how can we get that a little bit tighter to know if a patient had, went to their visit or needs to be seen. And that's I think a perfect example of where you can bolt on the BCDA data to an existing report or dashboard to help you get better information that's more actionable and more timely. Even just 20 minutes ago, or I guess 20 minutes before this webinar, I was on a call with one of our ACO participants, and we were talking through their primary care utilization, and we don't have a data connection with their EHR, and they were kind of stuck on like, okay, well, how do we know which patients to reach out to without reaching out to patients that may have already been in and had their claim, had a claim submitted. Small clinic, mom and pop shop, limited resources, and I jumped in and said, well, we'll take what we have. We'll take the BCDA data. we'll put the two together, and then you'll have your kind of your remainder of who you need to reach out to. So I think like there are endless. I think that's a cliche, but there are tons of possibilities. I think those few come to mind, but I think it's going to be a really powerful tool to help us as healthcare leaders be more decisive and more effective in what we do. And I really hope that CMS and others expand this type of data access.
Wonderful. Next question here, moving right along, is, and I think this is probably directed kind of in general, is what do you recommend for an organization looking to move the needle on specialty care?
That's a good question. So yeah, I think from my opinion, in terms of looking at this from a third party external data to, the first party internal data, I think what an interesting use case that I've seen very frequently across, our customers is how can we use third party external data to be able to identify, what specialty or what episode do we have the most opportunity relative to other ACOs or the region, for example? Is it, cardiovascular episodes? Is it musculoskeletal episodes like knee and hip replacement, for example? And from there, you can use the third-party external data to see how your costs and risk-adjusted costs compare to others. Then once you have that concept of, what specialty, what episode to focus on, then you can go into your, first party data and say, okay, who are we currently using for a certain set of episodes, or a certain service line like ophthalmology, cardiology, MSK. Then using third party data, right, you can help identify, okay, who are other high performing providers in a given market. And so the example that, I gave, I think it was probably like yesterday or 2 days ago that I was talking to an ACO about, you might have a specialist who sees 100 patients. Maybe only 5 of those patients are part of your organization. So in your first party internal data, you might only be seeing 5% of that whole entire provider's panel. So if you add on that third party 100% data, you get that higher N to be able to better assess how that specialist is performing. And so that's how you can kind of use that data to be able to come up with, whether it's specialist tiering, a referral strategy, and then use data like BCDA to be able to say, okay, so far in 2025, so far in May of 2025 even, where's our care going? Is it going to our tier 1, our preferred specialist, or not? And how does that break down by PCP? So I think that could be a good way on how to use that third-party data to get a more holistic picture on provider performance, and then use the first-party, more timely BCDA data to kind of track, those utilization patterns as well. But Justin, definitely interested in your thoughts on that one too.
Yeah, I think that's exactly it. And an example, I think like boots on the ground example is we were helping leadership in one of our markets try to understand their referral pathways and how they can improve them. And one area that we looked at is cardiology, and CareJourney has a cost and a quality score that basically tells you, how a specific group performs. And what we saw was interesting is that our own cardiologists were the best performers in the market, and then from there it just kind of like fell off. And so the conversation was, do we need to look at bringing in more cardiologists and expanding our cardiology services in this market? Absent that, here are the groups that we really need to, try to refer to. I think it's a little bit more difficult on the ACO side, but it really helped them inform their referral pathways, not only in the ACO, but across multiple different lines of business.
Great. Next question is this. It seems like you all have a strong provider buy-in and engagement around the data. Any advice to organizations trying to get there?
Yeah, I think it goes back to, I don't remember what tip number it was, but like don't try to boil the ocean. I mean, you can find trends and areas of variance. I think anywhere you want to look, and it's tough because you can really tire out your physician leaders with this trend and that trend. And I think that's why we were so successful with like the primary care example, is that we were really methodical about understanding where, that it was an opportunity, where we sat relative to other ACOs in the market, and to say, hey, there's like really no excuse to be lagging behind. And if we catch up, it's going to improve our ACO savings. And then also come in with a very specific recommendation on how to get after it, or how to accomplish improvement on a specific trend. And I think the other thing, it kind of falls in line with that, is just be really judicious about what you're going to ask providers to add to their workload. Um, I'm pretty far removed from care delivery unless I am in a doctor's office, and they're overburdened. We don't have enough primary care physicians in this country. I think that's well known, and so just be very careful about what you're asking them to do, and when you do ask them to do something, that it's really well thought out, and that they can see the connection to how it's going to make the patient's life better. And that's, I think, again, speaks to the success that we've had with the primary care incentive program.
Great. Okay, next question here. In the PCP visits by chronic conditions, did you look at only attributed practice or all primary care visits, regardless of rendering provider?
Can you say that one more time?
Sure. In the PCP visits by chronic conditions, did you look at only attributed practice or all primary care visits, regardless of rendering provider?
Yeah, great question. We looked at all primary care visits. It was that was a pretty big debate when we were going through and structuring the analysis. But in our opinion, primary care is primary care. Now, we did do some things to try to carve out like urgent care, ED utilization. We tried to really hone it in on, this was a primary care visit for primary care, and included that in our analysis. I think we're in a little bit of a unique situation where we have quite a bit of the market share here. And so it was probably a little bit easier to do than I think if you have a multi-group ACO, with no big health system behind it. But that's how we structured that analysis.
Cool. All right, next question is, has your organization seen a variance between the non-adjudicated claims coming from the weekly BCDA type feeds versus the adjudicated claims coming from the CCLFs from CMS? Do you see significant changes in claims outcomes?
I'll let Timmy probably answer this, but we're not that far down the road with the BCDA data to step back and say, here's what was, and then here's what the CCLF say, and here's the difference. I think it's a really good thing to keep an eye on. But I don't know, Timmy, if you've seen anything from your end, bringing all of that data together.
Yeah, we've done some interesting analyses where, for many organizations, we've loaded their CCLF monthly files. We've loaded the daily and weekly pre-adjudicated and adjudicated claims, and then looking at things like the quarterly and monthly expenditure report, depending on like what program you're in. And I'm going to try to visualize a line graph, so stick with me here. But you can imagine, like, for past months and stuff, it's basically lined relatively on top of each other. And then as you get to more recent, especially within the last 3 months, you kind of see the CCLF claims just drop off, right? And then you see kind of BCDA because it has more coverage as well too. So we've definitely done a lot of analyses around that. We've also looked at, what percentage of pre-adjudicated claims end up being adjudicated, and the impact on all of that. We haven't done, or what I had to look through, I should say, is whether or not we've done the financial assessment of that. I don't believe that spend amounts come across in the pre-adjudicated claims. It's more so, the procedure codes and the diagnosis codes as well too, which is super helpful for, a lot of the use cases we talked about. So in terms of looking at that piece, that's something I'll have to look into a little bit more. But in terms of trending CCLF versus, BCDA over time, that's definitely something we've done just to make sure that, they are similar as we would expect.
Great. Next question. Can you tell us a little bit about the EMPI process? Was it a part of the Arcadia integration?
Garrett, sorry, was it the
Sure,
ENPI?
I'll read it again. Can you tell us a little bit about the EMPI process? Was it part of the Arcadia integration? Does
I
that make
don't
sense?
think I have enough context to answer that question. Maybe if you want to spell that out
Okay,
more
yeah.
Yeah,
in follow up. Yeah.
yeah, we can definitely follow up on that as well too.
Yeah, for sure. And yeah, so if you ask that question, if you want to maybe drill down a little bit in that, and we'll move on to the next question here. Um, let's see. The next question is, and this one's probably, I guess, probably for Timmy. How is Care Journey's data different from the PUF?
Yeah, the puff. Yeah, that's a great
Oh,
question. We get that question a lot as well too. So for many of you, especially those with who are affiliated with an ACO, you all know the puff file, right? One row represents one ACO. It talks about financial performance, number of lives, and then each year I feel like there are more and more columns being added, which I think is great. I mean, just having the data out there for everyone to slice and dice, that data has been super useful for being able to understand drivers of, ACO success. I would say in terms of the care journey data, from the breadth perspective, we're able to calculate with that full Medicare data set a lot of metrics that don't exist in the puff file. Avoidable ED percentage, right? Applying open methodologies to the ACO population to be able to look at things like flu shot compliance, annual wellness visit, avoidable ED. I'm picking some of the more popular ones, but you can imagine there are dozens and dozens of other metrics that help expand, the breadth of the puff file. And then from the depth perspective, we can calculate those same metrics, but at the TIN level, at the MPI level, at the county level. So if you are an ACO and you have 12 TINs, you can say, okay, wow, TIN 1, TIN 5, and TIN 8 really have very low PCP utilization rates compared to the other TINs, right? And then you can double click on that and get down to the MPI level. And then from the geography perspective, as Justin was talking about, many ACOs have coverage across multiple states and service areas. It's important to be able to identify what TINs, what MPIs, what regions do we see that opportunity as well. And that helps provide, that context of depth that you might not get just in the puff Excel file, by itself as well. That's kind of my Spark Notes, 2-minute answer on that, but I could do a whole webinar dedicated to that. So.
for sure. Well, maybe we should have one. I did get some clarity on the last question, and a couple of you actually in the audience piped in, and even though it wasn't you that had asked the question. And so, what EMPI was referring to is the Enterprise Master Patient Index. Um, and the question was, can you tell us a little bit about that process, and was it part of the Arcadia integration? Does that make more
Um,
sense now?
yeah, that's a little far afield for me. If you want to connect with me, I can connect you with the team within Intermountain that worked through that. I'm pretty sure we use our own member number, MRN, but feel free to reach out and I can connect you if you have questions about that process. And I think Timmy on the Arcadia side can help out with that as well.
Exactly. Yeah, we can walk through our whole MPI process and stuff like that too. Yeah.
Very good, very good. Well, we are out of time, unfortunately. Thank you all so much for joining us today. Timmy and Justin, thank you for a fantastic presentation. As we close out, I wanted to encourage you all to head over to vbcexhibithall.com and check out the Arcadia virtual exhibit booth. This is where you can really do a deep dive on them and see what they're doing and see some of their research and resources, and of course reach out to them through there, and that'll sort of answer a lot of your questions. And of course, I'm happy to also answer your questions or facilitate an introduction. Also, this is where bbcexhibithall.com is where this webinar is going to be archived. And so if you wanted to see this after the fact, you can check in the reference library there and it will be listed. And we are also going to send you a link to where you can get the recording and download the slides from today's session. And then finally, if you would like to reach out directly to Timmy or Justin or the Arcadia team, feel free to do so. Their information is here on this slide. And again, I'm happy to facilitate an introduction as well if that's easiest. Thank you all so much. Again, thank you, Timmy. Thank you, Justin. Hope that you join us on part 2. And again, we'll be sending a link to register for that one in the thank you note that we'll send out here in just a little bit. But thank you all so much. Have a great rest of your day. Bye-bye now.